To be very informal meeting with our friend from Czech Republic, close to us. So I'm always refer, and you remember as well our Polish, German, Czechoslovakian network for surviving for many years, probably 20 years or something.
Oh,
luckily, more than 20, you think?
I was arrested.
You was once arrested.
On the German border.
With
Professor Maszyńska. Really?
Two of which no more
exist.
no
yeah.
more exist.
Okay,
DDR
okay.
and
You see, you're right. Okay. Anyway, our common interest is, of course, multiple myeloma problems, and every day we face with so many difficulties, so many aspects of heterogeneity of this disease, which is not probably more so terrible as it was before. Survival time was 3 years now. One of our patients, 14 years with multiple myeloma, will be subjected during next few days to subsequent high-dose chemotherapy.
Today, admittance is tomorrow.
He'll be admitted tomorrow. Anyway, I think it is. You have 21 subjects as well. So I think it became more and more chronic disorder with survival of at least 10 years if we do properly. Of course, it depends on cytogenetics, other risk factors, tumor burden a priori, kidney involvement or not, and so on and so on. But still, probably you, Roman, could clarify my small knowledge on multiple myeloma, which is such great variety of disease. Some have osteolytic damage, terrible damage with traumas. Some don't have at all. Some people have so great high level of mononuclears in peripheral blood, and they have no kidney failure. Some have. So probably so many factors: cytokines, chemokines, cytogenetics, of course, immunological abnormalities are taking part. But I'll be very happy if one day we could have MAPTERA for multiple myeloma, monoclonal antibodies against one of the cytokines. Probably it's not an IL-6, it could be IL-17 or other cytokines which play some role as a growth factor or factor stimulating osteoclast and so on and so on. So anyway, when I'm meeting for the first time or diagnose multiple myeloma in one of my patients, generally I could congratulate them. It's not acute leukemia. They have quite long lifespan in front of them, and I'm sure every year brings new idea, new hope, let's say. And I know you are working very strongly in this field, Roman. So you are our very, very welcome, cordially welcome guest and good expert, one of the best in Europe. We know it. We could learn a lot from you. Roman, the stage is yours.
Simplifying message from presentation is that there are many drugs in myeloma, but still only 4 key players: glucocorticoids, alkylating agents, IMiDs, and inhibitor of proteasome. And probably these key players will be key players for at least this decade and maybe the next decade. So this is the simple message of presentation. So now I can stop and we can discuss things. So, but starting with some introduction, that's what we are doing now. So we have a simple like myeloma. We are treating the patients, but the outcome could be, and we're trying sometimes, outcome could be cure. I strongly believe that really 10% of patients can be cured, and we just need still more and more data, maybe 10 years, and then that will be definitely proved. And if not, and it's generally for 90% of patients, then we at least are able to establish chronic phase of disease, as was nicely pointed out. And in some unfortunate examples, we can do opposite, so not good for patients, but probably wrong patients, to stimulate aggressive clone. So clear the very smoldering and indolent myeloma cells, and do space for aggressive clone, which then take privilege and is coming aggressive. Each result is the early, very aggressive relapse. We have also the different milestone now. This is not enough to talk about complete remission, but we are trying to measure the value, deepness of this complete remission, so talking about immunophenotypic or molecular remission. And especially the quality of remission is important in the term of longevity. So sustained remission after cut point, like 3 years, is really important and stronger prognostic marker now. So this is very sexy to talk about personalized treatment and targeted treatment. That's what we are not doing in multiple myeloma, I think so. We're trying our best to switch to personalized and targeted treatment, but the point is that we have no targeted treatment and no targeted agent, and we are not doing personalized medicine. What we are doing tailored medicine based on fragility of patients and conditions, different comorbidities. That's what we are doing, but it's probably not true personalized medicine based on some genes and mutations and markers and predictors. So what we are doing generally mix together everything what we have. So always trying now mix to novel agents and glucocorticoids and alkylating agents. So that's probably typical schedule for non-transplant or transplant setting, strong induction, plus minus autologous transplantation, consolidation, and if possible, and available maintenance. We know how strong data supporting the use lenalidomide as maintenance. So in our hand, at least in Czech Republic, what we are trying to do is VTD, starting with VTD now. Then melphalan, we are now in deep discussion to move from single to again double, despite I was against 7, 8 years ago, double. So I changed mind, sorry. So we still in discussion, but probably we switch from single to double. And then trying to use some type of consolidation, 3-4 cycles, no more. And we are really waiting for lenalidomide, which is, as in Poland, it's not allowed to use as maintenance in Czech Republic, but definitely I do believe that 2 years of maintenance or 18 months of maintenance of lenalidomide can really change the prognosis of patients. So this slide was presented for the first time with Antonio Palumbo, saying that now we have option to really strongly involve the setting of first relapse or progression. It was not possible before, but now we have really different drug from the same group, so we can really use even very effective regimen in the first, second line, third line. So that's the reason why the median of survival, overall survival, is so prolonged in patients in multiple myeloma. So, and there are so many drugs, and as I discussed, somebody can be confused what's really good and what is not good. But as I said, simplifying things, we have 4 key players with different mechanisms of action: alkylating agent, glucocorticoids, IMiDs, and proteasome inhibitors. So now, short introduction about proteasome inhibitors. I just can point it out that the 3 scientists was awarded in 10 years ago exactly with the Nobel Prize for chemistry, and discovery of ubiquitin proteasome pathway was really important, not only for myeloma, but generally for biology. This is proteasome on the left side, and this inner beta ring, hexagonal, has, this is green, the key proteases system, beta 1, 2, and 5. The important are all, unfortunately, the proteasome inhibitors involve mainly this beta 5. So they inhibit only this protease system, but that's probably the reason why some myeloma cells are resistant to proteasome inhibitor. And there are so many proteasome inhibitor now. One more or two more are outside this table. And there are different in inhibition, but all of them usually inhibit beta 5 in different manner, but no one probably from this 3 first approved in clinical setting inhibit beta 2. You can see differences between inhibition. You can see difference in this binding kinetics. Bortezomib is slow, reversible. MLN or ixazomib and carfilzomib are irreversible. You can see difference with half time, which is the longest for bortezomib. So they are approved or not approved, but it's coming. Another peroral oprozomib is coming. So we have at least 4 or 5 effective proteasome inhibitors now.
FDA relapse. Very relapse or
carfilzomib
already is relapse.
Carfilzomib was approved in the state in the relapse setting, but in the relapse setting. But what we know from how the physicians handle drug in the states, whenever is drug approved for any setting, then it's already used for all setting. So
is doing this in his first line.
that's what I'm saying. That's what I'm saying. Whenever it's approved for relapse, then you can use they can use it for all settings. So and this is probably difference between MLN 9708 and bortezomib. You can see that the only key difference is in proteasome dissociation, which is very short for MLN, and maybe this long dissociation has something to do with neuropathy introduced by bortezomib. That's the idea. So we always need predictors. When we will find some predictors, then we will probably do more personalized medicine. There is no case in proteasome inhibitors, unfortunately. This protease system is very complicated. There are several proteases, so there is not easy to just qualify the protease system with simply method. So this is probably one of ideas which would be important. This is the XPB1 regulator of unfolded protein response, and that seems that has something to do with bortezomib sensitivity. It was the next year published in Cancer Cells again, and it looks that cells XBP1 negative, there are some progenitor myeloma cells which persist in myeloma and they are resistant to proteasome inhibitor. So now we're trying to, and the research is trying to strategy to induce these myeloma cells to increase, be positive for XBP1, which has something to do with cell stress. And there are different methods how to do it. And actually clarithromycin can do it. I actually don't know why. I need to learn, but that's funny. So we have no predictors for proteasome inhibitors. Some introduction of IMiDs, you are familiar with them. So 3 of them, structure very similar, functionally slightly different. All of them are teratogenic, have DVT.
What's the situation with POM in your country?
POM, we have special program for pomalidomide. So simplifying things, we can treat 30 patients this year.
It's like Germany or okay? Because
No, it's not like Germany. We have a specific program, we can ask, but we can use it. So not for all patients, but fortunately can. So you can see different. Again, this is data for pomalidomide, but for thalidomide and lenalidomide are similar. Many mechanisms for action. You can see, but there are differences in anti-angiogenic mechanism of action, immunomodulatory action. There are differences between these drugs, as you can see here. Thalidomide is probably the most anti-angiogenic, but its immunomodulatory activity are really weak. What is interesting for me is for pomalidomide, this urinary excretion, which is really only 2% in in original form, so which is no problem with renal excretion and reduction if the pomalidomide is used. This is the advantage against lenalidomide. And again, we have no predictors. There are some movement and noise about cereblon. Probably it's interesting, but this noise is already for 3 years. And I know at least 10 research groups which really strongly working on it. One research building of Celgene working on it to make some simple test of prediction, and they still not finished. So it's not perfect, definitely. So we have no predictor for IMiDs, unfortunately. So summary of introduction of these drugs. Definitely, all of them have multiple mechanisms of action. Probably some of these mechanisms are still hidden for us. We don't know. Definitely, all of this drug has strong anti-myeloma effect. That's good for patients. There are not targeted drugs. I can't say it's targeted drugs. They involve many pathways. And we unfortunately have no predictors of sensitivity resistance. So then now, clinical part. So we have 4 drugs. Here are the candidates. And through the time, exactly because we have these strong drugs, we really increase the response rates and especially complete response rates. So if you remember the Watt story in the beginning of 19 or in the end of 80, it was 50 to 60% of overall response rate with less than 5% of complete remissions, and we have no knowledge about molecular remission or immunophenotypic remission at that time. Through the time, you can see significantly increase of overall response, complete remission, which is green, and currently used protocol has really potential in newly diagnosed patients achieved 100% overall response rate with at least 60 or 3/4 of patients complete remission, and most important probably 30 to 40% of immunophenotypic or molecular remission, which is really what we need. This is still big gap for other drugs, because that's what we can achieve with this strong combo. This is still gap for different drugs to achieve some level like in Hodgkin disease or something, but that's the potential of currently used combo regimen. So if we can see this schedule natural history, starting with some first hit and clonal expansion through early to late myeloma. So we usually treating patients in active myeloma, and as I said, I do believe that like 10% of patients with good risk, which is able to undergo autologous transplantation and stroke regimen, that could be probably, they have chance to be cured. What we are trying now is to do start therapy early, and you probably are familiar with the movement in smoldering myeloma, even ultra high risk smoldering. Now the researchers play game to start renaming this smoldering to early myeloma, which is advocacy to start the treatment basically. So we can start somewhere here, especially in high risk patients. And you know this cartoon which just demonstrates that at the beginning we have several clones, and the balance between clones through the course of disease is significantly influenced with the drug used. So that's, you definitely know this card, but why I say showing this is that if we are confident that we have already clones in the time of diagnosis, this is the lesson from biology, there are also clones here in the setting of smoldering, in the setting of MGUS. There are probably few numbers of clones, there are less resistance. We can use probably the therapy more effectively with curable, with with potential to cure, but they are definitely there. So why to wait here if we know that the clones are already here? And it just became, through the time of maturation, just became more resistant. And what we know from fish, jeep, array, next generation sequencing, there's just increasing genomic host through the time, nothing else. The key players are already there, and there are some switch buttons. We don't know which one, which does not, and something push this button, and then there's the reason why rapid transformation from MGAS or smoldering to progression to myeloma. So easily simplifying things, smoldering myeloma is already cancer, so we now trying to treat it. We have proof of principle trials. You definitely saw it several times, this Landex versus Dex, with really excellent outcome, even in the term of 3 years overall survival. It's still not good enough, but it's definitely proof of principle trial with good and positive results. There are running at least 20 others trials with different type of therapy, and basically what we are doing is, the left side is what we are doing currently outside trials, watch and wait strategy until the disease is symptomatic. Then many researchers doing this, playing game with low dose with different drug and trying to prolong the smoldering period of this disease. And there are some smart researchers, as I say, they are going for cure, so trying to eradicate. The balance between these trials is 90% versus 10%. But I do believe this is the important things, because if we offer to patients the chance to be cured in high probability, that's probably interesting for patients. From all these trials, this is only one trial with combinations, IMiDs and proteasome inhibitors. Here is presented on ASH by Ola Landgren. As you can see, 8 cycles CRD, carfilzomib, revlimid, dexamethasone. And this is the preliminary results. But you can see 100 response rate after 2 cycles, and after, in the end, best response, 100 response rate in the term, and 7 patients have complete remission or similar. So what we know more that most of these patients have already immunophenotypic or molecular complete remission. So this is probably, this type of disease is very sensitive, and it's really probably chance to be cured if we treat this patient early. And this is exactly the protocol of PETEMA, Spanish group. The next, which will be open, I think, this year. And you can see 6 cycles of RD. We already know that would be the peroral proteasome inhibitor, autologous transplantation, consolidation against, and maintenance combo of Landex plus elotuzumab. I don't know why elotuzumab, don't ask me. But the target is to evaluate proportion in sustained response at 5 years, and to increase number of these patients in sustained remission of 50%. So basically this protocol is really protocol going for cure. So if it will be successful, then we can really offer to some limited number of patients an early myeloma, really chance to be cured with high probability. That would be really nice. So we have to wait. So that was the smoldering. And multiple myeloma, that is just proof that it's probably important to combine this drug. Only VTD, Velcade thalidomide dexamethasone, has better result than VMP or VD. We know it. This is there are many trials already. This is trial in newly diagnosed from the States, and with maintenance by Velcade, I can just demonstrate response rate, VTD, VD, VMP, not significantly, but definitely better better VGPR significantly for VTD. So combo of these drugs is important. Now the provocative is if RD is enough, because if what we learned from the ASH this year, that was the presentation and several presentations, this one was the most important, that probably RD is enough for elderly patients, especially with comorbidities and so on and so on. There's this trial first, it's MMO20, compare LEN Lodex continuously, the same for 18 cycles, 18 months basically, and with MPT, classical, 12 cycles. And the results in terms of progression of renal was significantly better for continuous. We can say that definitely it is due to lenalidomide maintenance. That's looks, because otherwise the curves are very similar. And it was also proved by overall survival. So the conclusion was that probably the European physician have to change the mind and don't advocate too much or always melphalan, because this is our typical regimen, melphalan based. Yeah, because it's completely clear already, almost in the States. Nobody use it, at least upfront, nobody use it almost. And we still advocate this regimen, and maybe it's not necessary, especially for more fragile patients. So we will see. So, but that was one of the imperative of ASH 013. So what about novel or other approaches? Because you can combine always everything, but we need, we need see some, logic step or something different. The different is sequential alternating, coming again from Salamanca and Petema, and they saying, okay, we need novel agent, but why use it together? It's too toxic sometimes. Okay, use it sequentially. So they use MPV first, and then RD. And then in phase 2, this is not randomized, but in this phase 2, they use alternating therapy. It's mean MPV, RD, one cycle, MPV, RD, MPV, RD. And then compare this, if it's what is better and in the term of toxicity and in the term of efficacy. Response rates were actually similar, slightly better for alternating, but 89%, 94%. Strong number of complete remission, almost half of them, or half of patients. Especially, but in all arms was clear that patients achieving complete remission are doing better. All other difference were no difference. Toxicity and tolerability was similar. So the conclusion was, okay, we need to go to phase 3 to see what is better. There is another approach, again, starting with CRD, combination of all drugs, but then adding maintenance lenalidomide, because I think that lenalidomide of maintenance is key factor. The data are so strong, the benefit of maintenance is even better than benefit of transplantation for youngers. So we need maintenance, definitely. I don't know if for 2 years or 18 months or 3 years, but definitely we need it. So there's another play how to use and combine the IMiD and proteasome inhibitors. And as you can see, almost 90% of response rate with significant number, 67 number of complete remission or near complete remission. So the potential of this regimen is really strong. Carfilzomib lenalidomide is probably the strongest regimen currently used. And this is probably much better for us. If we can replace carfilzomib with bortezomib, then it's achievable in our setting, because bortezomib is coming to be generic the next year, and thalidomide is cheap already, so that would be good condition to combine this drug, definitely. So this is the Peter Sonneveld schedule, and you can see again overall response rate above 90% in before transplantation, after transplantation, after consolidation, after transplantation, but the number of complete remission are significantly different. Otherwise, I definitely think that we do need transplantation. Whenever it's possible to use transplantation as part of the regimen, that's important to use it. So that not to challenging transplantation with novel agent, but combine it. That's the important. And this is another from Italy group, Sarah Bringen. I can just demonstrate that we need to be sometimes patient. If you use this combination of drug, then still achievement on the maximal response is not sooner than after 10 months, and maybe the cutoff should be like 15 months. It's shorter than after conventional chemotherapy and interferon. It was 18 months, but now we need to wait at least 1 year. So, and this is MLN, ixazomib, first peroral inhibitor. There was several trials in phase 1 and 2. I will not go through, but summarizing thing, they combine it with Revlimid and dexamethasone. Of course, it was effective. The GI toxicity and fatigue were the key non-hematologic toxicities. Then switch to phase 3 trials with fixed dose of 30 milligrams in 1 week schedule. Very, very convenient for patients, even for physicians, because I can see patients 1 monthly. So now running these clinical trials, this is already closed. I don't know if you participate on it. Quite good trial, especially for patients. Easy to run, peroral regimen. I could see patients one monthly. That was really nice. So we need to wait for final outcome, but definitely the combination will be better than RD. And the same trials is now running in amyloidosis, which is interesting. So for ixazomib peroral inhibitor, very good results from phase 1-2 trials. My personal feeling that the toxicity, especially fatigue, is key issue sometimes. A lot of reduction, and there is no so effective as bortezomib. That's my feeling. That's only feeling. And some conclusion. So we have key player group with different mechanisms of action, representing with 3 many drugs. So we can combine it to very effective regimens, definitely achieving 100% of overall response rate, with at least 1/3 of molecular or immunophenotypic remission. And what we can do, and this is realistic for us, is VTD as first line, very effective. After switching bortezomib to sub-Q application, the neuropathy is not issue for us. Then we can use, of course, lenalidomide, carfilzomib, and then we can combine pomalidomide with ixazomib or oprozomib. So mixing these key players, that's really offer to patients at least 2 or 3 or 4 very potential and powerful therapy possibilities.
None of them are real cytotoxic drugs.
None of them. Yeah. So that was message. And moreover, as I, of course, pointed out, and it's important for patients, regimens are fully peroral, so very convenient for patient. And I don't know if it's true, but despite many novel agents evaluated now in clinical trials, I really do believe that IMiDs and proteasome inhibitor plus glucocorticoids remain key players and backbone of myeloma treatment, not only for newly diagnosed, but also for relapse setting, for at least for this decade. This is space for other drugs, but this is really strong. And that's all. Thanks for my colleague, and thanks you for the attention.